welcome all. Today we have Dr. Deepal and Dr. Chinky with us, who will be sharing their professional journey and more importantly talk about how they have implemented the things they have learned into practice and making a difference to patients' life at the same time experiencing the professional satisfaction and demonstrating what a pharmacist can do. So on behalf of Pharm.D students from India, we welcome both of you. Thanks for taking your time and we are very excited to listen to you. So over to Satya. Satya will introduce both the speakers and then you can take it from there.
Yeah, thank you so much, sir. Namaskar, everyone. I hope everyone is doing great today. If not, pay more attention to this session on integrating pharmacogenomics and nutrigenomics with value-based care to improve clinical outcomes. Trust me, this session gonna make your day productive. Tonight, this task of introducing our speaker, Dr. Chinky Bhatia and Dr. Deepal Soni is genuinely a great privilege. Let me walk you through their professional journeys. Our first speaker, Dr. Chinky Bhatia, was born in Kingdom of Byron. She developed an interest towards medicine, worked with her grandmother, who is an Ayurvedic practitioner. This led her to study pharmacy at Birla Institute of Technology, India. She immigrated to Australia in 2003, where she enrolled at University of Sydney to complete her Masters of Pharmacy, with a specialization in vitro fertilization. She was then awarded a scholarship from the University of Florida to complete her PhD in neuroscience in 2004. She acquired her PhD while working on multiple projects and writing her dissertation on the role of cannabinoids in short-term memory. During this time, she also served as a role model and mentor to young people, helping them plan for their education and careers. Since then, Dr. Bhatia has worked as an independent pharmacist and Ayurvedic coach when treating her patients with hormonal and pelvic health concerns. She likes to integrate the best of both worlds to get optimal health outcomes. After seeing a need for personalized medicine, Dr. Bhatia added a pharmacogenomics certification to her educational resume in 2020. She co-founded her company Core Care RX in early 2021, where she provides pharmacogenomics consultations, value-based care services such as chronic care management, along with Ayurvedic wellness consultation to healthcare facilities. She also serves as a preceptor to pharmacy students in pharmacogenomics. Dr. Bhatia runs a Facebook and LinkedIn group called Rejuvenate Your Health, through which she selflessly helps women with hormonal disturbances and anxiety. In addition to her busy professional practices, she is a mother of beautiful 6-year-old girl, Ananya. She loves to cook and enjoys hiking and other outdoor activities. And I'm elated to introduce our next speaker, Deepal Soni, who is a Pharm.D board certified pharmacist. She was born and brought up in Gujarat, India, where she completed high school. She moved to New Jersey, USA in 2005 to pursue Pharm.D. She attended Ernest Mario School of Pharmacy, Rutgers University, and graduated with highest distinction in 2012. Dr. Deepal Soni went on to pursue 1 year of pharmacy practice residency at Jersey Shore University Medical Center. Then, during this time, she worked alongside physicians in ambulatory clinics such as heart failure clinic, transition of care, pulmonary clinic, where she managed complex medications. So Dr. Soni was an integral part of an interdisciplinary team of different units such as critical care, cardiology, oncology, and internal medicine. Dr. Soni is a board certified ambulatory care pharmacist. She worked as a clinical pharmacist with major focus on transition of care and counseling patients. She co-founded Core Care RX in 2021, where she provides value-based clinical services to physician office and clinics, medication and wellness consultation integrated with pharmacogenomics and nutrigenomics. She also serves as a preceptor to pharmacy students in pharmacogenomics. Apart from her busy professional life, she enjoys spending with her husband and 3-year-old daughter exploring the beautiful state of North Carolina. So on the behalf of Pharm.D Doctors and Pharmacon Society for Pharmacy Practice, so we invite our today's speakers, and I'm personally excited to learn more on pharmacogenomics implementation. So the stage is set for you. All speakers, please go ahead.
Thank you so much, Dr. Karthik and Dr. Satya, for the lovely introduction. So I'm very excited and pleased to speak at this platform to the wonderful students who are the future of pharmacy. So I'm going to just go back a little bit and say a little tidbit about how we co-founded GoCare RX. Like Dr. Satya mentioned very briefly on how my journey of how I graduated with a bachelor's of pharmacy from Birla Institute of Technology, and then moved to Australia to complete my master's, followed by a PhD from University of Florida. So far, the work I had done in my PhD was on neurophysiology with a specialization in Alzheimer's and epilepsy that focused on basic science research. However, when I graduated with the PhD, I got an offer to do a postdoctoral study at Albert Einstein College of Medicine. But somehow I was missing the clinical interaction with patients. So I decided to go back into the world of practicing pharmacy again. I completed my board exams and then got an opportunity to work in the retail setting. I worked there for a few years, but somehow I was not feeling very satisfied after working there for a while. And the reason is because I felt that I was being stuck in the vicious cycle of medicine. My patients were getting an average of 14 to 15 medications every month. And either they were getting it to combat the side effects of one medicine, then another medicine, or they were being over-medicated, and in some instances, under-medicated. Many patients would come with questions on health, nutrition, and fitness, which I could actually answer. But the corporate culture of working did not allow me the time and the energy to actually answer their questions and answer each one of their questions. This got me a little, I'd say, depressed, and I just felt like I was being part of this corporate system where I was not treating each patient of mine as an individual. So this got me looking into other non-traditional pharmacy roles that were actually in line with my value system of individualized treatment. And as Dr. Satya wonderfully said, that I had a background in Ayurveda because of my grandmother, and somewhere I wanted to integrate the theory behind the individualized medicine. So that's when I came across pharmacogenomics, because pharmacogenomics, which I will be discussing soon, is precision medicine and also a part of preventative medicine. While going through LinkedIn, I came across Dr. Deepal, who also shared my value system of preventative medicine and precision medicine. And then we decided to get together and form this company. I will now pass it over to Deepal.
Thank you, Dr. Chinky. Thank you, Dr. Karthik and Satya, for inviting us to speak on our journey and the services that we provide on this platform. So as Dr. Satya mentioned, I graduated from high school in India, and then after my 12th, I came to USA and completed Doctor of Pharmacy in 2012. And during that, I always knew I wanted to be a part of hospital pharmacy system. So after that, I pursued 1 year of residency, where I got to round with physicians and residents and be a part of their team with nurses and other case workers to improve patient care on different floors like ICU, neuro, also part of like heart failure clinic, transitions of care clinic. And after that, I spent about 6 years as a hospital pharmacist. But what was different was that I was a floor pharmacist. That means I was working on the floors with the doctors and the physicians, verifying the physicians' orders and answering drug information question for nurses. So here in USA, most of the hospital pharmacists are all centralized in one department. but my role was different. I was on the floors, working in collaboration with the physicians. And also, each physician order that comes through has to be verified by a pharmacist before a nurse can dispense. So I'm not sure how it is in India, but that's a little different. When I was doing that, I realized there was a huge gap in care when patients were being ready to be discharged to home, because nobody was held accountable to review the accuracy of the medication list that they were being discharged on. Nobody cared if patients can afford the medication they were discharged on. And that's why I developed a transitions of care program for the hospital, and it became very popular and expanded through the entire hospital. Also, I quickly realized that when patients did go to home in the community setting, again, there was no accountability to follow up with the patients on how they are doing on their new medications, or if they are improving on their, or who is managing their disease state. So that led me to become a board certified ambulatory care pharmacist. And I started looking out for a different role, where I came across Dr. Chinky's profile and learned a lot more about precision medicine, like pharmacogenomics, and which played a big role in preventative care. So we got together and founded Core Care RX, and our philosophy lies in prevention and personalized medicine, and that's what our value system lies in. So throughout the program, we will first discuss pharmacogenomics, then go over value-based care services, how we integrate two of those services. We'll touch upon Nutrigenomics and end with the questions.
Hi, thank you, Dr. Deepu. So let's start with pharmacogenomics. And I'm going to start with like a true life incident about how pharmacogenomics could have prevented a fatal case from happening. So in April 2005, a mother delivered a baby boy. The delivery left the mother with debilitating postpartum pain. The doctor prescribed a painkiller which made the mother feel drowsy, tired, and sometimes constipated. She also noticed that her child wasn't breastfeeding well. So the doctors reassured her, saying everything is okay, and why don't you store your excess breast milk for convenience? But one day, unfortunately, the child didn't wake up. The child's skin was gray and wasn't breathing. So the mother called 911, but it was too late. The autopsy was done, and extreme levels of morphine were found in the child's blood, and infanticide was declared. This is a true case study, and the culprit in this case was found to be codeine, because the mother was prescribed Tylenol number 3, which is a combination of acetaminophen and codeine, and it is prescribed to many new mothers in the United States. Most mothers end up giving birth to beautiful, healthy babies. But what had happened in this case? So to understand it better, we will look into the concept of pharmacogenomics. So many a times we've noticed that for the same condition, the same drug either leads to no response, a response with a desired effect, or a response with toxic side effects. Now, we know that there are many factors that play a role in how our body responds to drugs. For example, you have physiological factors like age, sex, height, weight, race. You have extrinsic factors, and then you have intrinsic factors. So genetics is a great intrinsic factor which plays a key role in how a drug or how your body responds to a medication. So in effect, pharmacogenomics is the study of genetic variations that influence individuals' response to drugs. So for most of the medications, there is this family of the cytochrome P450 enzymes, which I'm sure you have heard of, that play a key role in metabolizing most drugs. There are 50 isoenzymes of cytochrome P450, and 9 of those isoenzymes are involved in metabolizing over 80% of the medications. Through the combination of alleles, I just want to remind you that we could, as individuals, could be normal metabolizers, ultra-rapid metabolizers, extensive metabolizers, and poor metabolizers. So until recently, medications have been developed with the idea that each drug works pretty much the same for everybody, which means there is a mentality of one size fits all, even for medications, in fact, diet, pretty much everything. However, genomic research has changed that one size fits all approach and opened the door to more personalized approaches to using and developing medications. For example, in this slide, we see the percentage of the patient population for which a particular drug in a class is ineffective on an average. So 38% of the people don't respond to SSRIs, which is actually a pretty big number. 40% of the people don't respond to asthma drugs. And look at this figure over here. 70% of the people don't respond to Alzheimer's medications. And we know that currently in the market, there are very few memory drugs available. So pharmacogenomics will play a key role over here, especially for psychiatric medications. So what exactly happened in that first case that I told you about, the mother and the baby? So the mother was given Tylenol number 3, which had codeine. Now we know that codeine is a prodrug and needs CYP2D6 to be converted into its active metabolite, morphine. In this case, the mother was an ultra-rapid metabolizer of codeine, which means she was converting codeine into morphine at a very fast rate, which led to the buildup of morphine in the child's blood and led to infanticide. So following this case and some other few cases with codeine, the FDA decided that to make a law that unless necessary, very low doses of codeine need to be prescribed to pregnant or nursing mothers. So does that mean that codeine is a bad drug? No, it is actually a very effective pain medication, but only when given at the right dose at the right time to the right patient. So how do we determine those right patients? By using and conducting pharmacogenomics. So just like the codeine toxicity case, there were some other fatal case reports in the United States, and especially with psychiatric medications. There was a 52-year-old female patient who was found dead in the psychiatric hospital. Initially, the people suspected overdosing of doxepin because the concentration of doxepin was 2100 nanograms per mil in the lady's blood. But on further analysis, they found that she was actually, and in fact, a CYP2D6 intermediate metabolizer, which is a one pathway for metabolizing doxepin. So this led to higher concentrations of doxepin to be found in the lady's blood, which was the cause of her death. Another very unfortunate incident was that of a 9-year-old boy, Michael, who had died from Prozac toxicity. So Michael initially suffered from Tourette syndrome, ADHD, and fetal alcohol syndrome. The doctor initially prescribed clonidine 0.9 mg and then later introduced Prozac at 10 mg and subsequently increased his dose to 60 milligram over the course of 3 years. Now we know that 60 mg is a very high dose of fluoxetine. Investigations from specialists found Michael to be a very poor metabolizer of CYP2D6, which led to very high levels of fluoxetine in his blood, along with the fact that he was on a high dose of Prozac. So cases like Michael and the lady from the psychiatric hospital, they could have been prevented had the doctor initially had the pharmacogenomics reports. Because especially for psychiatric medications, when you have the report, you can put the patient on the right drug from the beginning and eliminate the whole trial and error approach to prescribing medications. We know that psychiatric medications, especially like SSRIs, take between like 3 months to work. So in order to eliminate that waiting period and to put them on the best fit from the get-go, we should have the pharmacogenomics testing done before prescribing the medications to avoid these fatal accidents.
So pharmacogenomics not only play a role in psychiatric medication, but they also play a big role in cardiovascular medications. And one such example is Plavix or clopidogrel. So as you might have known that Plavix on its own is a prodrug, and it needs to be converted into its active form to show its protective effect against the clots. And in order to do that, CYP2C19 enzyme plays a big role. So CYP2C19 would convert a prodrug of clopidogrel into active form of clopidogrel. But if a patient is a poor metabolizer of CYP2C19, which is seen in subpopulation of South Asians, then they would not be able to convert a prodrug into active form, and hence it won't show its protective effect against the thromboembolic events. And a study was done which involved 30 to 60 patients, and they were given either clopidogrel or its alternative prasugrel to the poor metabolizers of CYP2C19. So the group that received Plavix had a higher incidence of thromboembolic events compared to prasugrel. So by doing pharmacogenomics and picking the right drug, there was a 6 times reduction in major adverse events and protecting patients against those fatal accidents. So you can see pharmacogenomics plays role in cardiovascular as well as psych, and also many other drug classes, as you will see in next slides.
So in this slide, I will be talking about tramadol. The reason I am going to be talking about tramadol is twofold. One, it is a prodrug and it needs CYP2D6 to be converted into its active metabolite. Second, it is actually one of the highly prescribed drugs in the United States. It's prescribed around 75 million times per year. So this makes it a great candidate for PGX testing. Now, poor metabolizers make up 5 to 10% of the population. So many a times in our practice, we must have seen that patients come to us saying that, oh, tramadol is not working for them. They need something stronger. As healthcare practitioners, it's our natural tendency to think that the patient is a drug-seeking patient. But in reality, the drug is actually not working for the patient because he's a poor metabolizer and he cannot convert it into the active metabolite to exert its effect. Now, intermediate metabolizers, of course, have a little bit of response. Normal metabolizers make 80 to 90% of the population. But keep in mind that normal metabolizers can also be turned into poor metabolizers when they are given with medications that are CYP2D6 inhibitors. So in my practice, I've seen that sometimes tramadol is prescribed with SSRIs. And we know that SSRIs are CYP2D6 inhibitors, which leads to tramadol not working for the patient. So once again, pharmacogenomics will not just help you find the right drug and the right dose, but it will also take care of these drug-drug interactions and highlight the drug-gene interactions. So to summarize, what are the benefits of PGX, especially if integrated with value-based services like medication therapy management and chronic care management, which Dr. Deepal will be speaking about soon? So genetic variations are a major cause of adverse reactions and are a huge burden on the American healthcare system. So what's the solution to that? The solution is precision medicine and to perform pharmacogenomics testing in order to maximize the intended use of the medication, to reduce adverse drug reactions, to speed the time to achieve the actual therapeutic benefit of a drug, especially for psychiatric medications, to decrease the chance of side effects or dependency, for example, with medications like tramadol, to identify the most appropriate and affordable drug the first time round and to avoid any trials and errors, and to reduce adverse drug reactions early in the treatment, thus impacting the length of stay in a hospital, hospital readmissions, and ER room visits time and money, which are a huge burden on the medical healthcare expenditures in the US. So PGX helps find the best fit drug from the beginning. Before I hand it over to Deepal, I'd like to talk about this quote that Core Care RX really firmly believes in, which is do as much as possible for the patient and as little as possible to the patient, because it's in line with the philosophy of Core Care RX that believes in treating the root cause of any disease and also believes in preventing chronic diseases from happening in the first place by making good lifestyle changes and following personalized medication.
Okay, so this is a slide where it highlights what services we provide. The core services are geared towards personalized medicine and individualized approach. So we use pharmacogenomics to find the best drug, Nutrigenomics for precision diet and fitness, because not everybody responds to the same diet in the same way. And last is Ayurveda life intervention, also including deep breathing and meditation. And that's how Dr. Karthik and I bonded on that topic. The other services which are value-based are transitions of care, chronic care management, comprehensive review of medications, and telehealth consultation. So let's talk about value-based care, which is patient-centered healthcare. Until last year, I had no idea about what is value-based care till I started studying for board certification. And then that's where I realized that the healthcare has shifted from volume-based to value-based. Now, everything in here, all the medical services are reimbursed by the insurance companies, especially the federal government. So what was volume-based? When a physician sees a patient in the office, they get paid based on the number of patients they see, whereas value-based is a physician gets reimbursed for making the patient held accountable for their own health and improving the healthcare goals. So in volume-based, there was no accountability. They were just getting reimbursed for even for 5 minutes. But it didn't matter if patient improved or not. But with value-based, it does matter. Now their reimbursement is tied to patient's performance. It is tied to quality measure. It is tied if patients are staying in the home rather than spending more days in the hospital. That's why it is very important that we focus on value-based services. And a team-based approach is very important when it comes to value-based, because physicians are already busy with their complicated patients. And that's where, as a pharmacist and being expert in medications and other counseling, we play a big role. And some of the services that I will be talking about in next slides are chronic care management and behavioral health integration. So what is chronic care management? Basically, it is a non-face-to-face services provided by the clinical staff of the physician for spending 20 minutes every month with the patient. And they must have at least 2 chronic conditions like hypertension, hyperlipidemia, diabetes. And as a pharmacist, we create a comprehensive care plan, which includes preventative care steps as well. And we also counsel them on lifestyle interventions like diet and exercise. It also gives us opportunity to review their medication list. In order to be eligible for this chronic care management service, a patient, we need a consent. And since this is a reimbursable service by the government, it is subjected to deductibles and co-pays, but patients find it very helpful because now they are hearing from a physician's office and or a healthcare provider on monthly basis. BHI or behavioral health integration is similar to chronic care management, but this service is more towards mental health disorders. So if a patient has at least one condition, for example, anxiety or depression or a substance abuse disorder, then they are eligible for behavioral health integration. And what we can do is follow up with the patient on monthly basis and see how they are responding to their medications. And we can do that by using validated rating scale. For example, PHQ-9 for depression. And based on the scoring, we can find out if a patient is responding to the medication or if they need a different medication. And if the condition is worsening, for example, they're going from mild depression to moderate or severe, then we can contact the physician right away and take necessary steps. Just like CCM, it is subjected to deductibles and copay, and patient do need to give consent to be enrolled in this service. So the benefits of these services are that it increases touch point from the office. Now, because they are hearing from office on month-to-month basis, rather than waiting 3 to 6 months for the appointment, all their questions can be answered during a short period of time. And all the clinical time that was spent before, which was not accountable, can be accounted for. For example, reviewing the labs or getting the prior authorization for medications. And this can identify problems if a patient is going through before they end up to the hospital, because going to the hospital is going to cost a lot more. And it also reduces hospitalization and improves the quality rating for the physician, as well as improve their reimbursement. Because again, to remind you, now the reimbursement is based on how well you treat the patient. Transitional care management, as I said in my introduction, I was in that role, transitions of care role, for 5 to 6 years. So I'm very passionate about it, and the role of pharmacist in TOC or transition of care is very big. So let's see what is transitions of care. So when a patient is residing home and they have to go to the hospital, so they are transitioning from one setting to another. And then from the hospital, they can either go home or a nursing facility. So again, now they are transitioning. So between each of this transition, there are chances of errors. What kind of errors that pharmacists can prevent? And those are inaccurate medication list. When a patient goes to the hospital, first of all, the nurses or a medical assistant, what they do is collect a medication list from the patient. Now, nurses or an MA, they are not so well versed with their medications. So sometimes they have incorrect dose, incorrect frequency. But when a pharmacist collect the same medication list, it is a golden list, because pharmacist will do a lot more detective work and will detect any errors, because they know the dose, they know the duplication, they know the interaction. And same thing when a patient is being discharged to the hospital, from the hospital, another again a medication list is reconciled for patient to follow that list at home, and nobody is accountable for that in the hospital. So that's where a pharmacist can again compare the list to the home list and make sure there is no omission, there is no discrepancies. Throughout the hospital, there can be many changes done in the medication. So we want to make sure those changes are reflected when they go home. And again, a big role of pharmacist is to make sure patient can afford their new medications, because not every medication is covered by their insurance. And if they cannot afford the medication when they go home, patients are not going to take it. And if they don't take it, they will come right back to the hospital. So that's why transition of care, catching errors, and making sure the safe discharge of the patient to home or back to the community is very critical. And as I already mentioned, it does cost a lot more. It costs about $17 billion each year for incorrect medication or improper use of medication or incorrect medication list. And 30-day readmission does happen because of errors in transition of care. And 30-day readmission is very important in US system, because if a patient gets admitted in the hospital within 30 days, neither does a hospital get paid nor physicians for treating the patient. That's why it is very important. 30-day readmission mark is very important. So some of the issues that patients face in community setting is that the healthcare system is very complex. Since there are so many players involved, there is primary care physician, there are specialty doctors, there are so many insurances issues, and since nobody is held accountable for all these patients fell through the crack, and then they end up coming back to the hospital. And I think that's where pharmacists play a big role, where they can catch the errors and fix it right away before patient end up in the hospital. So I almost like to think transition of care as a broken Pictionary, the Pictionary game, where one person says something to another, and another person interprets in its own way, and doctors make decision on that broken list of medication, and that's what it is continued. And when patient goes home, they have their own sleeve of medications awaiting for them at home versus a medication list that doctor gave. So many chances of errors, like omission. Nobody's looking for omissions or therapeutic duplication or drug interactions. That's why pharmacists play a big role in TOC.
Thank you, people. So coming to the next value-based care service, it's medication therapy management. And as a retail pharmacist now, we are required to do medication therapy management to reconcile the medications and make sure that the patients are not overtaking any medication or undertaking any medication, to improve the ratings of the pharmacies, so that they are still in the game of community pharmacy setting. So what is medication therapy management? They are services provided by a pharmacist that improve treatment outcomes for individual patients. It is a professional service to promote the safe and effective use of medications. It helps in providing better care for the patients and making them responsible and taking charge of their own health, because counseling plays a major role. It also aids in collaborating with patients and also collaborating with other healthcare providers, so that you end up working as a team to take charge of the patient's health and to teach them better ways of living. So what is the spectrum of a pharmacist-led MTM? Well, it helps in running comprehensive medication reviews. It helps in adherence services based on the number and the type of medications the patient is on. It helps in working with targeted medication intervention programs, that is to catch the high alert medications or high cost medications and to maybe switch it to the low cost ones but equally effective, to educate them on the high alert medications and be responsible with them, like Coumadin. And it also helps with interventions for certain patient populations like geriatrics or pediatrics, which need a little more extra attention. It helps in managing certain disease states, chronic diseases like diabetes, hyperlipidemia, asthma, HIV. And the most important part of MTM, which I really like, is that it takes action into health and wellness services like wellness screenings, immunization, smoking cessation, alcohol reduction, weight loss programs, etc. So what are the core components of the MTM service model? One, it's the medication therapy review, which is a review of all the medications, including prescription, non-prescription, herbal, dietary supplements, and even nutrition. And this typically takes between 1 to 1.5 hours to finish by the pharmacist, and it's reimbursed by the government. The second, to create a personal medication record so that they can use it like a passport when they go to several different doctors, or maybe they move states and use other pharmacies. It also entails creating a medication-related action plan for the patient, which lists what the patient needs to do next and what the physician needs to do next. It allows for interventions and referrals to other doctors or other healthcare providers. It allows for a very thorough documentation and follow-ups to keep a regular check on the patient. So this is an example of a personalized medication record template, which shows the details of the patient on the top, and then you have the name of the medication, the strength and frequency, the condition the medication is taken for, and the physician who prescribed the medication, and any notes that you would like the patient to refer to when you are not around. It also lists the allergies, because you should remember that there are many geriatric patients or many patients that are not educated enough to understand that they have certain allergies and they should keep a tab on them. It also allows for pharmacy prescription drug plan, as to remind them when they need to take what, or any other note about the medication that the patient should be aware of. This prescription record is always with the patient, and we also try to send it to the physician so that it's in their electronic health record. This is a template of the medication action plan. I hope you can see it, but this is basically the interaction that we had with the patient, and it is a documentation of it. This document is then sent to the patient and also sent to the physician. And after the physician reads this, the physician takes charge of whatever changes need to be done. And we wait for the physician to make those changes and then document it in the MTM program again. And again, we get reimbursed based on the changes that we are made and the changes that are implemented. This is sort of my favorite because it serves as a reminder to the patient about what the conversation was all about. So this is a schematic that Core Care RX follows on how we integrate PGX with MTM or CCM. So you could easily have MTM over here or CCM. So first, the pharmacist leads the medication therapy review, which typically lasts anywhere between 60 to 90 minutes. Then we create the personalized medication record for the patient by deleting, by deleting any unnecessary medications or introducing, all of course in collaboration with the physician. Then we give them pointers on their disease state management. For example, if it's diabetes, asthma, what they need to do, how they need to take care of their inhalers, when they need to take it, basically teach them on how to take charge of the disease management. Based on what we see in the medication therapy review or CCM, we identify and screen them as candidates for pharmacogenomics testing. We then create a medication action plan, which I showed you, and a little more elaborated one after seeing the results of the genomic testing of what drug is right and what dose should be right for the patient. If any changes are done or not done or anything new that we found from the genomic testing, we create an action plan based on that and discuss it with the physician. Once the discussion is done, we then convey the message to the patient and give them another counseling session. We then follow the patient for a few months to see if the medication is effective, if they are adhering to it, if there are any questions or concerns that they may have, including educating them on any preventative services or wellness screenings that they need to do. And then this cycle continues because we run another CMR for them in the next few months. All right, so that was the end of the value-based care services. Now, more recently, at Core Care RX, we've been diving into this new innovative technology called Nutrigenomics. So what Nutrigenomics is that it is the effect of food on gene expression, how nutrients change your gene expression, not genetic variation, but gene expression. So a very famous functional medicine doctor, which you may have heard of, Dr. Mark Hyman, has very nicely said that your gene expression can change based on what you eat, how you move, your thoughts, feelings, and social connections. And I think that this is a big component of personalized medicine because medicine and food go hand in hand. You can't expect to get better by just one component. So a combination of pharmacogenomics, nutrigenomics, and other lifestyle changes are required to lead to a better health and wellness outcome. So nutrigenomics and nutrigenetics are not interchangeable terms. This is because nutrigenetics is the study of how your genes affect how your body responds to food, versus nutrigenomics is the study of how what you eat affects how your genes behave. So frequently we get asked this question like, why does Core Care RX do nutrigenomic testing? Or why are we interested in understanding gene expression related to diet? So this is our simplified answer, that when you are on a certain diet, like carbohydrates, your genes may be upregulated or downregulated based on the amount of carbohydrates you have. And also, if you are, let's say, on a low or a high protein diet, certain genes may be upregulated or downregulated, affecting how your genes behave. For example, if we know that there are these certain food groups or certain macro or micronutrients that make our genes behave badly, then we can try to change our diet from the get-go so that we are not leaning towards the propensity of certain diseases caused by the bad gene behavior that the diet has led to. So we can catch it right from the beginning and avoid that from happening in the first place, because gene expression changes with what food we are eating. So again, this is a preventative measure that is preventing something rather than treating it post-consumption. And I really like this quote, which says, one person's superfood can be another person's poison. A good example is that of caffeine. With caffeine, some people consume caffeine and they are hale and hearty and very active and very mentally alert, because they may be fast metabolizers of an enzyme that plays a role in caffeine metabolism. Versus if someone has the poor metabolizer of that enzyme involved in caffeine, that person is not going to be active. Rather, that person's cortisol level is going to go up and the person is going to be sluggish and depressed and prone to cardiovascular diseases. This is also published in a paper. So what is it that a normal Nutrigenomics report generates? So we get the recommended diet type, like a broad distribution of macros and micros, like how many carbs a person should be taking, how many lipids a person should be taking for the best health outcome, and how much protein the person should be taking. And you would be surprised, because nowadays there is a trend that if everyone goes on a keto diet, which is a high protein diet, then the person will end up losing weight and the person is going to feel really good with clear skin. But that is not true for all patients, because some patients may benefit from a high protein diet, but some may not. Some may need more carbohydrates, and unfortunately carbohydrates are now thought to be the bad guy of a diet. Also, it gives you the micros, so you know how many vitamins you need, how many greens you need to eat. It gives a very a nice breakdown of this category. It also tells you the intolerances that you may have or your DNA may have towards certain things, like caffeine that I spoke about, lactose, alcohol, and fructose, which is interesting because not many people actually think about intolerance to fructose. Many do think about lactose intolerance. It also gives you your propensity to your vitamin and mineral deficiency risk, and then provides you with the supplements that you may benefit for, either in the detoxification process or just to feel better, overall energetic and strong. It gives you a daily calorie intake based on your BMI and your genetic makeup. It tells you, interestingly, what physical activity will work for you. Again, we have started thinking that high intensity interval training works for everybody, but some people may just be more benefited from aerobic training than HIIT, or some people, you know, it tells you whether how the endurance training is also going to affect your cholesterol levels, the propensity of effect on your cholesterol levels, mainly the HDL level. It gives you a complete genetic result profile and your propensity to diseases like diabetes, obesity, and other conditions that you may think of. And then at the end, it has this 3-phase supplemental nutrition plan for detoxification.
You're on mute.
People? Okay.
Sorry.
So,
Yeah, I was on mute. So after talking about all the services which are geared towards precision medicine, personalized and individualized, and also the value-based, we have created this model where pharmacists are leading some value-based services like CCM, MTM, remote patient monitoring, and then combining that with a personalized, individualized care, empowering patient on their and taking and making them accountable for their own health, which has led to improve outcomes, decrease healthcare dollar spending, and also improve the rating. And that's basically what we follow and what we believe in at Core Care RX. So thank you so much for this platform. We had a great time sharing our journey, our services, and what we do. We can take questions now. And if you guys want to reach, we are available via LinkedIn. And also we have our website. The QR scan is right there. And also our Instagram and Facebook handle is Core Care RX. And we are excited to hear from you now.
Yeah, so thank you. It was very inspiring listening to you on various services you are providing to improve the care. So are there any questions? Yeah. So from participants. So can somebody read out that question from you?
No.
I will read it out. So does all medicines are affected by pharmacogenomics and nutrigenomics?
So right now, the FDA has, I think, between 250 to 300 medications that they have approved for pharmacogenomic testing, which I would say, because there are so many medications in the market, every few months you are having some new medications coming and joining that list. But for psychiatric medications, there is a large group of medicines which are affected by the cytochrome enzymes, which are already there on that FDA list. More studies are being done on diabetic medications. I think right now you have glyburide and glimepiride on that list, but much more work needs to be done to expand that list to more disease states other than psych, oncology, HIV medications, and I'd say some immunology medications are on the list, but more work needs to be done on diabetic medications, cholesterol medications, etc.
Mm-hmm. So in terms of ACE inhibitors, for cardiovascular, we have seen a role of PGX in statins, beta blockers, and antiplatelets. Have you heard anything about ACE inhibitors?
No, I haven't, not yet. There is metoprolol, which is a beta blocker on the list.
Yeah.
Can I add a point here? Sorry.
Mm-hmm.
So for ACE inhibitors, as of now, there is no significant pharmacogenetic interaction with respect to the metabolism, but some literature is going on with directly ACE receptor, which is kind of pharmacodynamic interaction, not pharmacokinetic. So which is still, data is limited, still the research is in like preliminary stages, maybe in future.
Yeah, more to come.
And it's happening fast because technology is moving very fast too. And research is, many people have invested in this area of research now in the US too.
Mm-hmm. So the medication reconciliation or MedRec, There are two kinds of MEDREC when a patient comes to the hospital. First one is admission MEDREC. That means as soon as patient enters the hospital, staff creates a medication list by asking the patient. Sometimes they have the full medication list. A lot of time they don't, and nobody pays attention investigating and forming the correct metric. So sometimes there is a omission, or a dose is missing, or a frequency is incorrect. And then there's a discharge metric. So that's the list that a doctor creates in the hospital when patient is ready to be discharged to home. It differs from MedSync because MedSync is used mostly by community pharmacy, where they are keeping track on patients' refill. So MedSync calls, and once patients are getting low on their medication, they will automatically renew the medication. Anything to add on MedSync calls?
Yeah, I just wanted to add that there is a habit of patients to come refill their medications like 15 days in advance or 20 days in advance. And sometimes to keep the patient in the store and to not disappoint the patient, or to sometimes they lose their medication. Sometimes someone steals their medication. So to keep that, we end up doing the refill. But as community pharmacists using medication synchronization, we try to push them, to a date where they can get all the medications at the same time, because this way their level of adherence will increase, their responsibility will increase towards their strength and towards their medications and health. And the way we do this is by handing them a few medications just to keep them a few pills just to keep them going on that date where we want the synchronization to happen. Mm-hmm. And that's very different from MTM too, because MTM is done by pharmacists. And MTM had all those components that we spoke about, which are a CMR, which is a comprehensive medication review, the TIPS, which is therapeutic interventions, and then the medication action plan, followed by a brief summary to the physician. And it's billed to to Medicare, which is the federal insurance.
Most of the data is now electronic. Now there is a big push from the government to have all the record as an electronic health record, and actually physicians get good rating and good quality measures for keeping all the records centralized in electronic, because it can be shared with other physicians in case they change, so there is no duplication of work. So the government is not spending money for the same test or same blood work. So the digital record is what most physicians follow now.
So there is a question from Anirudh about the role of nutrigenomics in free radical or reactive oxygen species. Honestly, Anirudh, I haven't come across that yet, because this is something new that we ventured into and we are still learning. And our focus so far has been on nutrigenomics and diabetes, and also health and fitness. Deepal, are you aware of it?
I'm not. No.
Okay. Yeah. Because. Yeah. So far, how do we identify patients at risk? I understand that the population is really large in India, but the way it works for us in the US is using the chronic care management. Because as chronic care management pharmacists, we have a certain number of patients who we need to call every month. And we have to go through their complete profile, like, what work they got done, blood work they got done, how long have they been taking their medications. We end up bonding with them because we also know of the social and environmental factors that are affecting their mental and physical state. their annual wellness checkups done, and the report then enters the CCM system. So because we are so aware of the medication of the people, we know them, we end up knowing them and working with them for years together. We know whether a certain medication is working for them or not and needs to be changed. And tools like CCM and MTM then work best for us to screen and identify the patients. But it is time consuming. It is not like you will end up knowing if the patient is a pharmacogenomics candidate just from a 1 month sitting.
Mm-hmm. Nutrigenomics role in case of immunocompromised or special population.
I mean, we are aware of the diabetic populations, and currently we are actually in the process of hopefully writing having our grant approved and collaborating with a doctor to show the role of nutrigenomics in diabetic patients in the South Asian population. So we are trying to do the research on a small set of people and see how it plays a role in improving or managing diabetes. But other than that, we haven't ventured into immunocompromised patients.
Mm-hmm. Where can we access view genomic linked ADR stats? Most of our article search is through PubMed. So if you search for pharmacogenomics related ADRs or med related ADRs and role of pharmacogenomics, you will get a lot of publication.
And in addition, you can also look at the CPIC guidelines, which is the consortium for pharmacogenomics. And I think there is like some good information there on individual drugs that play a role in pharmacogenomics and a good amount of data about them.
So Alvin, you can stop YouTube stream. So any participants, do you have any feedback to share?